Hello everyone, I am Dr. Mahalakshmi, educator, forensic medicine and toxicology. In this video, we are going to see about autopsy techniques. So, autopsy technique will deal with what are the techniques that we use for opening the body, what the techniques that we use for removing the organs and how we dissect those organs, and what are the things that we have to preserve in an autopsy. So, all these things we will be seeing in this chapter. So, first autopsy techniques, we are starting with incision. The first is the incision. This incision is very important and it is frequently asked. So, incision you have few types. So, first we are starting with I shape. Then you have Y shaped, modified Y shape, inverted Y, X, T. So, these are the different types of incision that we normally use. So, first I-shaped incision, this is the most common. In all autopsy, we prefer this. So, what happens is that this will start from chin. You will start from the chin and it will go down like longitudinally, it will go straight down till umbilicus. There it will make a turn, like around the umbilicus it will make a detour, then again go back to the midline and it will go till pubic symphysis. So, what will happen is that if this is your chin, we will start from here and this is your umbilicus. So, this will go like this and this will go back to midline again and it will end in the pubic symphysis. So, this is how it is usually done. So, starting from the chin, go down straight in the midline and it will take a detour around the umbilicus and it will go straight again to the pubic symphysis. So, this is the I-shaped incision that is commonly used. Now, next what we have is Y-shaped incision. So, here what will happen is that it will start from the mastoid. You have Y, right? So, Y means you have two limbs. So, both side mastoid. Mastoid on both sides, it will start like this, two limbs of Y it will come and it will converge here at the sternum, angle of sternum. It will converge here and from there it will go in the midline till pubic symphysis. Till the pubic symphysis it will go. In all the incision there will be a detour around the umbilicus. Like if it is a umbilicus present here, it will take a detour like that. All the incision will avoid the umbilicus. Why? Because is that this umbilicus, it has a dense fiber tissue. So, because of this dense fibrous tissue, we normally just spare the umbilicus and go around it because it will be really hard to cut. So, we will leave the umbilicus and we will go around the umbilicus. So, Y-shaped incision, it will start from mastoid on both sides and it will join at the sternum and it will go down till the pubic symphysis as a straight line in the midline sparing the umbilicus. This is your Y-shaped incision and this Y-shaped incision, it is used in neck trauma. Whenever there is neck trauma, if you want to preserve the neck structures like hanging, strangulation, where you have to open the neck and see the internal changes, muscular changes, you have to preserve the neck. If it is an I-shaped incision, the neck will also be incised, right, in the midline, which is not correct. So, if it is a neck injury, if it is any asphyxial death like hanging or strangulation, you have to spare the whole neck. So, what we prefer is this mastoid to mastoid sternum incision known as Y-shaped incision. Clear? We have seen I, now we have seen Y. Next to the Y-shaped incision is your modified Y-shaped incision. So, here what happens is that the incision, the two limbs of the Y, it will be going beneath the breast. So this is the breast, and beneath the breast it will go. The Y-shaped incision will go beneath the breast, and here it will go till the umbilicus, and again it will go to the pubic symphysis sparing the umbilicus. So this is your pubic symphysis, umbilicus, and sternum will be here. So this type of incision where we are going beneath the breast, here we are going beneath breast, this is known as modified Y-shaped incision, and this is mainly done for cosmetic purpose. If it is a female, if you don't want to disfigure the body, if you want to make it very simple, you can do this sort of incision, and this is only for cosmetic purpose. There is no other use for this incision. You will simply go under the breast, and in the midline, after that you will be going. So I-shaped, Y-shaped, modified Y-shape we have seen. Now you have inverted Y-shape. So in inverted Y-shape, what will happen is that you have the inverted Y. So here from the chin, it will come as a single limb, and if this is umbilicus, just above umbilicus, just above umbilicus, it will split into two limbs of Y, and it will end in the inguinal canal. In both inguinal canal, it will go and end. So this is your inverted Y-shaped incision. You see Y is inverted here, that is why we call it an inverted Y-shaped incision, and this incision, it is preferred in infants or fetus. Why? Because there we have to see the umbilical cord. So we are just sparing the umbilicus. This way we can see if there is any abnormality in the umbilical artery or vein. Any congenital abnormality in there, we will be able to identify. That is why we use this inverted Y-shaped incision, and it is preferred in fetus and infant death. So this is inverted Y. Next what we have is this X-shaped. So X is, it is usually given in the back of the body. Over the back of the body, we make this X-shaped incision, and this is done for torture death. In torture death, if we do autopsy, what we will look for is any torture has been inflicted upon that person or not. Any beating has been done or not. So what we will do is, we will make an incision over the back to see if there is any deep-seated bruises. So usually if someone is inflicting torture upon somebody, what they will do is, they will beat over areas where bruise will not readily be visible. Like they will cause injury over the soles and the palm, or they will beat over their back. This is where normally you will get deep bruises. It will not be readily visible over the skin. In all other places where there is loose fat tissue, their bruises will be very much easily visible. But if there is injury over the soles or over the back, or especially over the your posterior aspect of the leg, calf especially, posterior aspect of leg, calf, in all those places you won't be able to identify the bruises very easily. So there you have to make an incision to find out all these deep bruises, and this X-shaped bruise, it is a X-shaped incision, it is mainly used to identify those deep-seated bruises. Clear? So this is your another type of incision. Then finally you have the T-shaped incision. So here what will happen is that the two limbs, okay, you will have the acromion on both sides. So acromion on both sides, from there you will get two limbs and it will converge over the sternum. Just like your Y-shaped incision, it will converge over the sternum and it will go in the midline till pubic symphysis. This is your T-shaped incision. So in Y-shaped incision, we started from the mastoid. So both mastoid, it will converge here. So your neck is free, but here and all, the base of the neck, these posterior aspect and the lateral aspect, it is not free. So in this case, what we will do is, we will start from the acromion process. So why we are doing this is that if we want to visualize the vertebral arteries, to visualize vertebral arteries. Or if there is any severe neck trauma like any cutthroat injury or something, if it is present there, you want to preserve the whole neck structure. If you want to see any pathology, you don't have to make incision over it. You have to just preserve all the areas, the whole base of the neck, lateral aspect of the neck, everything should be preserved. That is why we prefer this wider incision which start from the acromion process on either side. So this T-shaped incision, it start from the acromion, converge over the sternum, then again go in the midline till pubic symphysis and going around the umbilicus. Every incision will avoid the umbilicus. So these are the commonest incision types that is used in autopsy. All the autopsies, they will use at least one of this incision, and most commonly used incision is your I-shaped incision. What we have to know is where it is starting and what is the use of that incision. That thing we have to know. So this is your incision technique. And next what we have is organ removal technique. Organ removal technique. So here what will happen is that you have opened the body. Now we have to take out the organs, right? So what happens is that there is one law, like that is something usually followed, that you have to open skull first. So skull should be opened first. Why is that? Is like if there is any poison, it is usually more like you will be able to appreciate more readily from the skull. Okay, if you more open the skull first, and that smell, it will be coming out of the brain. So especially in poison deaths, you will be able to appreciate the smell more. So we usually open the skull first, and this opening up of skull will help in draining the blood easily. So this is why we do opening of skull first. So this is how organ removal is started. And next step what we have to do is we have to examine each and every organ, right? It has to be a complete autopsy, right? So how we are removing this organ, that is important. So first we have certain techniques for that. So first technique is Virchow, you have Ghon, then you have Letulle, then you have your Rokitansky. So these are the commonly used autopsy techniques for organ removal. So how we remove in each and every techniques, we will see. So what happens is that, what happens in Virchow is that we will take organ one by one. So Virchow is the most commonly used technique, and we will remove organ one by one. We will take out every organ. We will first open the thoracic cavity, we will take out the lungs, we will take out the heart, then we will open the abdomen, we will take out the stomach, intestines, uterus if it is a female. Like each and every organ is dissected separately and taken out. So this is the Virchow's technique, and this is the commonly used technique. Now the main advantage here. So advantage is that thorough examination can be done. Thorough examination of each and every organ. You can do detailed study. But there is one disadvantage. So disadvantage is that the interrelationship between the organs, the regional lymphatic supply, the vascular supply, all those interrelationship, it will be missed out. So interrelationship of organs will be missed out. So this is the main disadvantage in this Virchow technique. This is the most commonly used technique, but the main disadvantage is that it cannot keep that relationship between the organs. Since you are dissecting each and everything separately and taking it out, the interrelationship will be missing. But still you will be able to examine each and every organ thoroughly. So that is the main advantage of this Virchow. So up next what we have is Ghon's. We have Ghn's technique. So here what you will do is, you will do an en bloc dissection. Ghn's is en bloc dissection. What we mean by en bloc is that you will take out the blocks of organ, you will take out the thoracic block, you will take out the abdominal block, by system wise you will taking out them in blocks. So this kind of technique is known as Ghn's technique. So with Ghn's technique, the advantage that you get is that, the main advantage is that here this interrelationship is somewhat preserved. Interrelationship is preserved. Maybe not the perfect interrelationship, but since you are taking out as a bunch, the interrelationship will be somewhat maintained. And disadvantage is that, the main disadvantage, you will not be able to handle easily. Not able to easily handle the organs. Since you are taking it as a bunch, it will weigh a lot. So you will take both lungs with heart, it is a very big bunch, right? So examination would be kind of difficult. So that is the disadvantage with this Ghn's method. Up next what we have is Letulle. So Letulle methods, what we will do is that, we call it as en masse dissection. So what we mean by en masse dissection is that, we will take from tongue till the prostate as a single mass. So from tongue till prostate, a single mass is taken out. Okay, so completely you will just strip it away. A whole block will be coming out. And the advantage of this is that, the main advantage, you will have all interrelationship. Interrelationship would be perfect. But the disadvantage, the same thing, it is extremely difficult to handle. Extremely difficult to handle. This is the main disadvantage in this Letulle's technique. And next technique, that is very important technique, frequently asked, that is your Rokitansky. So Rokitansky technique, what happens is that, here you will do in situ dissection. In situ dissection. So here what will happen is that, you will not take the organ out. You will simply make an incision, you will open the flap and you will dissect every organ, keeping it inside the body. So organs are inside the body. You will not take it out. You will not take them out. This is Rokitansky method, and this is preferred in cases with infectious bodies. Highly infectious, like COVID deaths, all kind of infectious death, we will do this. And if it is a case of infant or fetus, we will prefer this Rokitansky method. And the main disadvantage with Rokitansky is that, what would be the disadvantage? Here you will not be able to do thorough examination. Thorough examination will be missed out. Complete visualization of the organ cannot be done in this Rokitansky method. So we basically have 4 types of incisions: Virchow's, Ghn's, Letulle's and Rokitansky. This incision types and this organ removal types, this is very important, and it is very important for your university exam and also NEET PG exams. And this has been asked multiple times, and you must know, if there is some question on autopsy techniques, it definitely will be this question. So this organ removal, first Virchow, you will take out the organ one by one, and this is the most commonly used technique. Advantage, each and every organ can be thoroughly examined. Disadvantage, the interrelationship between the organ will be missed out. This is your Virchow's technique. Up next you have Ghn's technique, which is also known as en bloc dissection, because you are taking out the organs in block. You will take out thoracic block, you will take out abdominal block, like that system wise, block wise you are taking out the organs. Here the advantage is that interrelationship would be maintained, and disadvantage is that you will not be able to handle the organs properly because it will be a bunch. So that is the main disadvantage of this Ghon's technique. Up next what we have is the Letulle's technique. Letulle, what you will do is, it is an en masse dissection. We call it as en masse dissection because we are taking out from tongue to the prostate. The whole bunch, everything will be stripped away from the body, and you will have a single bunch with having all the organs, your thoracic organs, abdominal organs and all the pelvic organs, everything will be taken out as a single mass, and it will have a perfect interrelationship. One issue is that you will not be able to easily handle the organs, you will not be able to weigh them separately, you will not be able to dissect them properly, and dissection will be very, very difficult. You will not be able to orient the organ. So all these problems will come up in this Letulle's technique. And next what we have is Rokitansky. So Rokitansky means in situ dissection, where you will simply dissect the organ keeping it inside. You will not take it out. Every organ will be kept inside the body and dissection will be done in situ. And this is preferred in infectious bodies, and infant and fetal death we will prefer this. Disadvantage is that thorough examination cannot be done in these cases. So this autopsy technique very, very important to remember, and it can be asked as a short notes. Clear? So with this we are done with the whole organ dissection removal techniques. Now we are going to specific organ dissection. So I told you skull opening and brain dissection is done first. So skull opening techniques, what we usually do is, we will make the skull flap. Like scalp, you will make it into flaps. 2 flaps you will make. Then you will open the skull by making circumferential drilling. Like you can use a driller or you can use a chisel. So what you will use, if this is the skull, what we will do is, we will open up the flap. Like scalp, it will be just removed. This will go like this and go like this. Your scalp will be taken into 2 flaps and you will expose the skull. And in the skull, along the circumference like this, you will drill them and you will take out the skull cap. So skull cap is removed, and beneath that you will have the dura. So in the dura you have to examine all the sagittal sinus, like all the venous supply, whether the vessels is having any bubbles or not. All those things you have to examine, and you will have to see if there is any damage to the dura, any hemorrhage is there, any cyst is there, all those things you have to examine. Then you will strip open the dura, you will cut open the dura, then you will have the brain, and brain, all the connections you will cut them and you will take them out for examination. This is how it is usually done in adults. And this skull opening technique, this is completely different in case of infants. And this infant skull opening, this is important. Infant skull opening technique, it can be asked as a question. So this infant skull opening, what happens is that the infants, their skull is very, very malleable. It is very, very fragile. It will not be as hard and calcified as an adult skull. So what happens is that you have 2 techniques. You have bars and Benekes. These 2 techniques are used for opening up the skull in case of infants. Up to 5 years of age, their skull will not be completely developed. So these 2 techniques are used for opening the skull in infants. So what happens is that you will, like if this is the skull, what will happen is that this will be the midline, and just medial to the midline, just lateral to the midline, you will make flap. You will put incision, and using this, like along this incision, you will use a scissor and cut open the skull. Like since it is very, very soft, not calcified as the infant, as the adult skull, you can easily open them using a scissor, and you will make 2 flaps. 2 flaps of skull, and this is known as Wernicke's technique. So, if you open it by making 2 flaps, by making incision lateral to suture. Okay, just lateral to the midline suture, if you make an incision and open the skull by using 2 flaps, it is known as Wernicke technique. But if you do 4 flaps, like a butterfly, like this, so if you open using 4 flaps, we call it as bars technique. So you will use scissor and you will open up like a butterfly, like a petal of the flower. Okay, flower petal, you will open the skull. This is known as bars technique. So bars and Wernicke, it is very important technique that we use for opening up the skull. If it is a normal adult skull, we will make circumferential drilling and open up the skull cap. But in case of infant, it will be very soft, so you will open the skull like this. And after opening up the skull, you have to examine for all the changes. If there is any embolism present, if any air present in the vessels, that you have to see, and any extradural or subdural hemorrhage present, that you have to examine, or any other cyst present there, arachnoid cyst, something is there, you have to do complete inspection. Then afterwards, the one important thing that we have to know in this brain dissection is that there is something known as fixation of brain. So what happens is that the brain will become very soft after death. So when you get the dead body, it will be usually sometime must have passed after the death. So what will happen is that for examining the brain completely, you have to do fixation of brain. So we will put the brain in formaldehyde and we will leave it for some 24 to 48 hours. After that, the brain will become firm. And if we cut open the brain after that, we will be able to identify all the pathology easily. So this fixation of brain can be done. If there is no urgent need, we can do it after proper fixation. But if it is a case of some hemorrhage, what we have to do is, we have to know whether it is a case of extradural hematoma or subdural hematoma or subarachnoid hematoma or parenchymal hematoma. This thing we have to know for sure. So what happens is that if it is above dura, then it is a case of, like dura, you will have that shiny layer over the brain. If the hematoma is present over that, then you can say that it is an EDH. And if it is present beneath the dura, after opening the dura, if you are seeing any hematoma, then you can say it is an STH. So it is below the dura. After opening the dura, you can see. Now, if it is beneath the arachnoid layer, then you can say it is an SAH. Now, what the issue is that you will be confused between these two, STH and SAH. EDH you can easily identify. But if it is an STH or SAH, you have to do something to find out. So what will happen is that this arachnoid, it is a very transparent thin layer. It will be closely attached to the brain parenchyma. You will not be able to see it separately like your dura. So what you have to do is, if you see hematoma over the brain after removing the dura, if you see hematoma over the brain, you have to pour water over it. So you will pour water over your brain, and if the hematoma washes away, then it is a case of SDH. If does not wash away, it is a case of SAH, because beneath the SAH, beneath the arachnoid membrane, you will be having that SAH. So if it washes away, it is SDH. If it does not wash away, it is SAH, subarachnoid hemorrhage. And if it is seen inside the parenchyma, if you cut open and see the hematoma, it will be known as a parenchymal hematoma. So this is the important thing that we have to know in brain dissection. Next, what we are going to see in organ dissection is heart. So heart is very important. Like brain, heart, it will lead to lot of sudden death. In lot of sudden death, we will find serious causes only. And heart dissection, we usually start with dissection of the coronaries, and after removing the heart, we will take it, and first we will look for coronaries, your left and right coronary arteries. Now there is something known as dominance, right? So right dominant and left dominant, how we will identify is, we have to trace out the left artery and right artery first, and this is usually seen between aorta and left auricle, and this right coronary, it is seen between aorta or pulmonary trunk. Mostly along the region of the pulmonary trunk you will be seeing, and right ventricle. Like where you have the pulmonary trunk, that origin, and between that right auricle and that pulmonary trunk, you will be seeing this origin of the right coronary artery. Now you have to trace the artery from the ostia, aortal ostia, both things they will be originating from that ostia, that origin point we have to trace them, and we have to follow them throughout their course, and we have to determine which is giving supply to the posterior septum. Okay, this posterior descending artery, which branch is giving, whether left coronary artery is giving branch or right coronary artery is giving this posterior descending artery, we have to identify. So whichever side is giving this PDA, like if left gives out this posterior descending artery, then we call them as left dominant, and if right side coronary artery is giving this branch, then we call them as right dominant. So this is how we determine the dominant. And this coronary arteries, after inspection, after you trace the pathway, what you have to do is, you mainly look for any bridging or tunneling, under myocardium. So this bridging or tunneling under myocardium of these coronary arteries, this can result in sudden death. This is one important cause for severe sudden death. So this thing you have to look for. Then you have to palpate it to find out whether they are firm or hard, like whether there is any calcification present or not. You have to find it out, and once you find it out, what you have to do is, you have to dissect the coronary arteries. And why we do this dissection is that we have to look for thrombi or emboli or plaque, or any narrowing. If there is any narrowing, any obstruction in the cross section of the artery, we have to look for. So you can either cut it a transverse cut and longitudinal cut also you can make. But to exactly know about the lumen, this lumen study, you prefer these transverse cuts. This is how you usually dissect the coronary arteries. And how you make this transverse cut is, if this is your artery going, if this is your artery, you will make transverse cut like this. Between every 2 millimeter interval, you will make a transverse cut, and you will look for any obstruction in the lumen. It can be either a thrombi or emboli or any calcification. That thing you have to find out, and while cutting you will be able to find out whether it is hard to cut, whether it has calcified or not. All those atherosclerotic changes you will be able to identify. And longitudinal changes, you will be just putting a, starting from the ostia, you will just put a longitudinal cut like this. In the center of the lumen, you will make a longitudinal cut, and most commonly we prefer these transverse cut. Longitudinal cuts are normally not done. So this is the coronary artery dissection. Once you are done with the examination of the coronary artery, what you have to do is, you have to look inside the chambers of the heart. So how you look inside the chambers of the heart? you have to cut open the heart. And when you cut open the heart, how you will do is, you will cut open along the path of blood flow. So, how the blood flows? Right atrium, right ventricle, pulmonary trunk, left auricle, left atrium, left ventricle, aorta. That is how it goes, right? So, you have your right atrium to right ventricle, then you have the pulmonary trunk, left atrium, left ventricle, then you have finally the aorta. So, along this way you will cut each chamber. So, you will cut the 4 chambers like this, and while cutting you have to look for the valvular changes. First you have to look at the size of the valve. Any difference in the, like any regurgitation, whether it is not closing properly, whether closure is proper or not. So, these changes in the valves you have to note. Then you have to look for any vegetations or papillary muscle rupture. All these things you can look at the cross section of the heart, mainly the valve circumference. The circumference and opening of valve, it should be measured. This is very important because there are a lot of valvular diseases, a lot of valvular stenosis that can result in death. So, these things can be seen while opening the heart, and it is usually done along the pathway of the blood. This is how you usually do. And there is one more way where you can cut open the heart, and that is by giving cross section. So, what will happen is, if this is your heart, what you will do is, you will make transverse cut like this. So, you will make cuts like this. So, by doing these cuts, you will get separate pieces, and there you can examine the myocardium. Okay, you can examine how the myocardium looks like. So, myocardium examination, it can be done like this. And in the myocardium, what you mainly look for is if there is any old infarct or recent infarct. This is what you something mainly look for. For old infarct, it will look grey or white color. That specific region you will be able to identify. Any ischemic changes, any old infarct you will be able to identify. And this recent infarct, it is like up to 1-2 days you can be seen these infarcts only using the histological methods. You have to put it under the microscopy to identify. But after 2 days, between this 2 to 3 days, you will get something known as tigroid appearance. Like the stripes in the tiger, okay, like how they have stripes in the tiger. There will be changes seen inside the myocardium, and using this you can identify. So, this is where myocardium inspection looks like. And after that, what you have to look for is the ventricular hypertrophy. Ventricular hypertrophy. What is the size of the septum, that interventricular septum, size of the actual ventricular walls, all the size you have to measure. And this cross section you will be able to see, like in the cross section this will be the lumen, and around that you will have the myocardium, right. So, this thing you will be measuring between the lumen and the myocardium, you will be able to measure this, and you will have to find out whether there is any hypertrophy or not, septal hypertrophy present or not. So, all those things you have to look in case of heart dissection. This heart dissection is very important because most of the sudden death will have some changes in the heart. So, heart, first you have to look for the coronary artery changes, whether thrombi is there or emboli is there or any infarct is there or any calcification is there along the pathway. You have to find that out, and you have to look for the posterior descending artery which is branching off into this posterior descending artery, whether right or left, that you have to identify. And you can also strip the arteries and you can like preserve it under formalin, you can preserve it and use it for further histological examination. So, we will start off with coronaries, then we will look inside the heart. So, you will cut along the pathway of blood and you will look for valvular changes, any vegetations or any papillary muscle rupture, any changes around the valve you will be looking for, and you will also be looking for the size of the valves, any regurgitation, stenosis if it is there, you will be looking for the valvular changes. After that you will look at the myocardium to see any old or new infarct. Then you will look at the size of the ventricular muscle to find out ventricular hypertrophy. So, these are the important dissection techniques that we need to use in the heart. Clear? So, after that what we will do is, we will look at the area of our interest. If it is a case of like gunshot injury or stab injury, what you have to do is like that area of concern. Area of concern is where we usually dissect. Dissected first, and we will look for all the changes in the area. There are certain special techniques that we have to do in autopsy to find out certain causes. So, first we will start with pyrogalol test. So, this pyrogalol test, it is used to identify air embolism. So, what happens is that this pyrogalol, this is something very colorless, okay, this is colorless, but on exposure to oxygen, it will become purple color. So, it will give some color. So, this is the nature of this pyrogalol reagent. So, what will happen is that if you are suspecting air embolism and if you do this pyrogalol test, that air will react with this pyrogalol reagent and it will turn purple. So, that is the thing of this thing. So, that is the use cut before that. So, that is the reason for using this pyrogalol test, because even after post-mortem death we will have so the pyrogalol test, it is basically used to identify air embolism. Like even after death, in the post-mortem period, there will be accumulation of air inside the vessels and certain organs. So, to differentiate whether it is a post-mortem accumulation or ante-mortem air embolism, we use this pyrogalol test. How we differentiate post-mortem versus ante-mortem air accumulation is that this ante-mortem air embolism or accumulation will have oxygen in it, and this post-mortem air, there will be no oxygen. So, if you subject the pyrogalol reagent to that air, we will be able to identify whether it is changing color or not. By using that, we will identify whether it is an actual air embolism or simply a post-mortem accumulation of air. So, that is one special technique that we have to know. After that, what we have to know is X-ray. X-ray technique, and this X-ray, it is useful in lot of cases, especially your pneumothorax. In pneumomediastinum, pneumothorax, all the cases where you suspect this accumulation of air. So, pneumomediastinum, all the cases. See, this X-ray technique is useful. Then apart from that, you will use it for all the firearm injury. You will use it in hanging or strangulation to see the hyoid bone fracture. And you will also use it in accidents, road traffic accident, to visualize fracture, like small bones fracture, like your finger bones, toe bones, all those fracture you will not be able to visualize in the physical examination. These fracture you will be able to identify perfectly in X-ray. So, this X-ray technique is used in lot of cases, especially in this firearm injury and hyoid bone fracture. So, whenever a case of firearm injury comes to you, like be it a gunshot injury or some sort of like bomb explosion, these things. So, we will use them to locate the missiles. To locate the missiles, we will use these X-ray. So, we will see whether the bullet is present inside the body or not. To identify that, we subject the body to X-ray first and we will do the autopsy later on. And later, what we use is that there is one technique for identifying embolism or pneumothorax. So, when a patient comes with pneumothorax, it is something very acute, right? They will present with pneumothorax and they may die very acutely. So, under such condition, how you visualize pneumothorax is that, so first you have to look for any crepitation, like subcutaneous emphysema, whether it is present or not. You have to palpate and find out externally. And after that, what you have to do is, you could make chest flap. Like in the midline, you will cut open and you will make 2 flaps of chest. You will open it, like flap up to anterior axillary line. You will just raise the flap, like skin and subcutaneous tissue. Using only skin and subcutaneous tissue, you will cut open the flap, and you should make sure that you have not incised the intercostal muscles or any tissues over that. So, it should be carefully done. And what you have to do is, once you raise the flap, you have to fill the chest, like the area between that skin and the chest wall, you have to fill it with water. So, you will fill it with water, then carefully you have to put incision under water. See, under the water, you have to punch the intercostal region. So, intercostal region, you will make an incision, and if there is air present, you could see the bubbles. Air will come out as bubbles. So, this is the technique that we normally use for identifying pneumothorax. Pneumoperitoneum also you can identify like that. So, what you will do? You will raise the flap and you will fill it with water. Then under the water, you will make incision. So, water will be there and air when it will come out, you could see the bubbles. So, this is how you identify whether it is a case of pneumothorax or not. And if it is an air embolism, we will use that Virchow test to differentiate between antemortem air embolism or postmortem accumulation of air. And one more thing that you can identify is that if it is a venous emboli, like if you are suspecting in the venous system, venous air emboli, what you have to do is, you have to mainly look at the IVC. You have to take out all the abdominal contents and you have to look at the IVC to see whether any bubble is present there or not. And if you are expecting arterial air emboli, you have to look in the carotids and in the dural vessels. There you could see clear bubbles. Okay, so this is where you usually look for this air emboli. So, this is how the special techniques is usually done in the autopsy. So, if you want to see brain, how will you open the skull, how will you dissect the hematoma, and how will you dissect the heart, myocardium, valves, and ventricular hypertrophy, myocardial infarcts, how will you identify? All these things are very important, and in special technique you need X-ray, Virchow test and opening up of the chest in case of pneumothorax. So, these are very important special techniques that we have to know in the autopsy technique. Now, once you are done with the autopsy, what you have to do is, you have to collect and preserve the sample, and this is also an important part of this autopsy. Without this, autopsy is never complete. So, usually what we preserve is the viscera, the internal organs. What we routinely preserve, we call it as routine viscera preservation, and it includes stomach along with its content. Small stomach along with its content. And stomach, how we cut open is that we will tie the stomach at each end. So, esophagus and gastric junction, then gastric and duodenal junction, there you will tie. Okay, both sides you will tie, and after tying you will cut them open and cut them open. So, you have removed the stomach from the body. Now, after removing the stomach from the body, you have to cut open the stomach, and this is usually cut along the greater curvature. So this is how stomach is open, and you will open the stomach and you will look for any mucosal changes. Any hemorrhage is there or not, any reddening is seen or not, simple congestion is seen or not, any ulcer changes is seen or not, all those things you will be looking in the mucosa. So this is how you cut open the stomach, and you have to examine the content which is present inside the stomach. You have to find out the nature of the content, whether it is solid or liquid or semi-solid, whether any peculiar smell is coming out, whether blood is there as a content or not. All those details regarding the content you have to mention, and this is the first thing in routine viscera. And after that, what you will preserve is, you will preserve half of each kidney. So basically, why we are preserving this viscera? It is for toxicological analysis, right? So what we do is, we will take the point of entry, that is your stomach. So from stomach, it will go to liver for metabolism, right? So you will take liver pieces. A piece of liver will be taken, and after it is metabolized, it will go to the kidney for excretion. So we will take half of each kidney. Why we are taking half of each kidney is that sometimes that some people will have kidney failure. Only one kidney will be working and another kidney will not be working in few people. So in order to avoid that issue, what we do is, we will take half of each kidney. So either kidney is working, we can get the either sample and we can identify the excretion of the drug. So that is why we take half of each kidney. So we have taken the point of entry stomach, we have taken the point of metabolism, that is your liver, and point of excretion, that is your kidney. Now apart from this, you also have to preserve blood and urine. So these are the routine viscera that we preserve. If people is asking for routine viscera preservation, we only preserve this much: stomach, piece of liver, half of each kidney, then blood and urine. This is what we usually preserve. But there are certain scenarios where you will have to preserve few other samples, like you will have to preserve brain if it is a case of alcohol or anesthetic death or any other CNS depressant poisoning. So inebriance, all those cases you will be preserving brain. And spinal cord, all the spinal poisons. Okay, in spinal poisons you will be preserving spinal cord. Any spinal poison, anything that rings with dog button, do we know any spinal poison? Strychnine, right? So strychnine you will be preserving in spinal cord. And CSF, it is present in alcohol, and heart is present in all cardiac poisons. So your digitalis, oleander, everything you will be preserving, all the cardiac poison you will be preserving heart. And vitreous is used in decomposed case. In decomposed case, you will be preserving vitreous for toxicological analysis if you are not getting anything else properly. And in methanol and ethanol, you will be preserving vitreous. And lungs in all inhaled poison, like your irrespirable gases, any other inhaled poisons, you will also be preserving them in anesthetic death. So this lung is preserved, and while preserving the lung, especially in case of this inhaled poison, what you have to do is, you have to tie the trachea. Okay, you have to tie the trachea and you will cut. After tying the trachea only, you will cut the lung and you will separate the lung, and you will preserve it in the common salt solution, like saturated solution of common salt you will be preserving. And over that solution, what you have to is, you have to pour viscous agent over the preservative. So why we are doing is that, so that the air from the lung should not escape. Okay, so we will just pour the viscous agent over the saturated solution of common salt. So this is how lung is preserved for inhaled poison. And skin, any injected poison or any bites, like scorpion bites, snake bite, all the animal bites, you will preserve the skin. And adipose tissue, it is preserved in OPC. Your pesticide poisoning, okay, you will be preserving the adipose tissue. And bile, all the drugs that has intrahepatic circulation like your opioids, barbiturates, you will be preserving the bile. And spleen is mainly used for microbiological analysis. So this is where you will be preserving some extra tissues after the routine viscera preservation. So normally the routine viscera that we preserve is stomach along with its content, piece of liver, half of each kidney, then blood and urine. This is the routine viscera. In few poisons, few circumstances, apart from this routine viscera, you will be preserving all these structures. So these are the things that we usually preserve in certain poisons. Now we have already told you that we will be taking blood. So blood collection is very important. It is a part of routine viscera preservation. Now where will you take this blood from? That is also an important question. So this blood collection will be done from the periphery, mostly your femoral vessels. This is where it should be done. Why? Because is that if it is a case of poisoning, if it has been done before the death, the poison would have entered the system. Then if you are seeing that in the peripheral vessel like a femur vessel, if you are detecting the poison in the periphery, means the poison has actually been in the system, not introduced post-mortemly. Like that we can identify. And one more thing is that there is something known as post-mortem diffusion. So what this thing is that, like there will be some suspicious activity that can happen. If somebody has died of some other reason, people might try to make that look like a suicide. So what they will do, they will put poison inside their mouth. Okay, that will be passive diffusion, or just at the moment of dying, they will pour it and they will make it look like they have consumed poison. So when you take sample from the stomach and do the analysis, you will think that there has been this poison consumption and death was due to that poison. Like that we will think. But actually if it is present in the periphery, means it has entered long before the death and it has actually circulated throughout the body. That is why we prefer this peripheral samples. And apart from that, there is something known as post-mortem diffusion. What happens in that post-mortem diffusion is that in the stomach, if the poison is there, the poison present in the stomach, after the death, due to loss of the cell wall integrity, the cell wall integrity will be lost after death. This poison, it will slowly diffuse. Okay, this will diffuse into adjacent structure like your lungs, heart, liver, all the adjacent structure, it will simply diffuse. So the poison, it will be diffusing into all these, and we might think there was extra concentration of the poison, and that could have been the cause that we will be falsely thinking. So in order to avoid that, in order to avoid this post-mortem diffusion phenomenon, we take blood from the peripheral vessel. And if there is blood clot, sometimes post-mortem clotting of blood will occur and you will have clots readily available in the cavity. Readily available in cavity. This clot should also be avoided. Should be avoided for toxicological analysis, because they will give you false positive result or abnormal values. So this clot should also be avoided. But there is one condition where you can prefer blood from heart. So heart blood, it is preferred for microbiological analysis. If there is microbiological analysis, then you can use the blood from heart. So this is how you usually preserve the samples. Now we have taken the samples. What we have to do is we have to preserve it so that the analysis could be done. The analysis is usually done at forensic science lab. Forensic science lab. This is where all the toxicological analysis is usually done. So from your autopsy table, from your institute, you have to send it to the forensic science lab. So it will take lot of time. It will not be done instantly. You have to preserve the samples. So there are certain preservatives that we use for doing that. So what are the preservatives? First is your saturated solution of common salt. Next you have rectified spirit, and sometimes you won't use any preservative, and sodium fluoride also you will use. So these are the most commonly used preservatives. We will see each and every one. First is your saturated solution of common salt. This is the most common and cheap preservative that we use. In all the cases we will be using this preservative. So it is very easy to make. You will just simply mix the common salt like the table salt with water and you will get the solution. So you will put the organs in that and you will send it to the forensic science laboratory. So this is how you preserve it. And in some cases we use rectified spirit. So rectified spirit, it is also known as ideal preservative and it is very costly. So rectified spirit, it is an ideal preservative and very costly. Now why we don't use this rectified spirit is that it is contraindicated in certain conditions which are very commonly found. Like it is contraindicated in these. Like you can use them, the mnemonic face pack and remember. It is contraindicated in formaldehyde poisoning, formic acid poisoning, chloroform, ether, phenol poisoning, phosphorus poisoning, alcohol, chloral hydrate and kerosene. In all these poisoning, you cannot use rectified spirit because these will interrupt the analysis. So this rectified spirit is contraindicated in all these poisoning. But all these poisoning, they are most commonly found poisoning. See, this alcohol, phosphorus, phenol, formaldehyde, everything is very commonly done, especially kerosene. In our setup, these are very commonly found poisoning. So even if it is an ideal preservative, it is a costly preservative and it is contraindicated in most of the commonly used poison in our country. So we use this saturated solution of common salt as the most common preservative. Clear? Normally, common solution of saturated solution of common salt is used, but rectified spirit is an ideal preservative since it is costly and contraindicated in few important poisoning. We are using the salt solution only. So this is the use of the preservatives. And sodium fluoride, this is used if you want to do preserve vitreous. So vitreous preservation, you can use sodium fluoride, and if you want to do blood alcohol, in case of alcohol, blood alcohol estimation, you will preserve the sample in this sodium fluoride. And no preservative is required if you are using bone or nail for analysis or if there is instant analysis. So under these circumstances, like if you are preserving a bone or nail which will not go away, so this bone and nail, we can just send it just like that. And instant analysis, like you are taking the organ out and within few hours it will be analyzed. In such cases, you don't need to preserve anything, right? So any preservative need not to be added in those cases. So this is about sample preservation. And the sample preservation, rectified spirit, where all it is contraindicated, this is important. They will ask you which all condition you cannot use rectified spirit. And this is the conditions: formaldehyde, formic acid, chloroform, ether, phenol, phosphorus, alcohol, chloral hydrate and kerosene. These are the poisons where you cannot use the rectified spirit. So this is how we usually do the autopsy. So autopsy technique, how will you do the incision? How will you remove the organs? And once you remove the organs, how will you open each and every organ? How will you open the brain? How will you open the heart? All these are very important. And once you do the examination, you have to preserve the sample. So you will correct the sample and you will preserve them using these commonly used preservative: saturated solution of common salt, rectified spirit and sodium fluoride. So these are the preservatives that we usually use. So, this completes the autopsy techniques. But there is one more important thing left, that is your exhumation. This is also a different type of autopsy. So, what exhumation means is that it is lawful digging up of dead body. So, once body has been buried, you will go and dig that up and you will do autopsy. This is exhumation. So, this is mostly, it can be either first autopsy or second autopsy. But what is like, it is already buried. Whether autopsy was previously done or not, it is a buried body. You will dig it up and you will do the autopsy again. So, this is the exhumation, and this exhumation, it can be ordered only by magistrate. So, what happens is that somebody would have died of some natural causes. People might think that there was a natural cause and they will bury the body without any suspicion. But after few days or after few months or years, some suspicion will come. Under such circumstances, people will go and complain to the police that we want to do autopsy because we are having some suspicion over his death. Like that, people will go and complain. Under those circumstances, the police will take the case to the magistrate and they will get the permission for doing this exhumation. So, they will go pick the body up and they will subject the body to autopsy. Or sometimes what will happen, even if autopsy had been done already, people will say that the doctor did not do the autopsy properly. Something wrong had happened, so we want to do second autopsy. Like that, people will complain. So, again you have to get magistrate request and you will dig up the body and do the examination. So, it can be either a first autopsy or it can be a second autopsy. Whichever is the autopsy, there are certain things you have to follow. First is that order from the magistrate for exhumation, that has to be done. Second thing that you have to do is identification. That burial ground, the exact place of burial, it has to be identified. Exact place of burial has to be identified, and you will go start the exhumation early in the morning. Early in the morning, we will start digging up the body. So, what will happen is, you will layer by layer, you will take the soil out. Soil is removed layer by layer, and like once the soil is removed to an extent, after that they will use their hands and they will take, if it is in a casket or if the body is put like that, what will they do is, they will try to make a opening, like they will try to leave some space around the body, and they will try to lift the body as a whole. And after lifting the body, what they will do is, they will collect soil sample from that place, from that burial place, they will take soil sample. And if the body is very much disintegrated, if it is in a very decomposed state, then on spot autopsy will be conducted. Whatever part is available, if it is only bone is available, then you have to preserve bone. If whole body is available, it was like buried some few days before, it is like very fresh, in those kind of cases you can do complete autopsy. But if you are getting only bits and pieces of body, or you are getting only bones, then you can preserve whatever you have. And main thing why we are preserving soil is, we have to do toxicological analysis. So, what we will do is, we will take the soil, and most common thing that deals with this poison is the arsenic poison or some heavy metal poison. So, what will happen is that the soil will already have some arsenic. Arsenic is present abundantly in the soil. Now, when you undergo the a toxicological examination for that body, you will be coming across some heavy metal. So, if that heavy metal, example arsenic, is present there, you might think that the death might have been due to arsenic poisoning, like that you will think. But the thing is, since the body is buried in the soil for a very long time, the arsenic from the soil could have entered the body. We say this known as Imbibition. Postmortem imbibition, like simply the arsenic from the soil will diffuse into your body. This is known as postmortem imbibition. Because of this imbibition, your body will show arsenic level, and people will wrongly think that it is a case of arsenic poison. To rule out whether it is actually an arsenic poisoning or postmortem imbibition, we have to test the level of arsenic in the soil. So, we will take the soil sample arsenic level. So, arsenic in soil. If it is greater than arsenic in body, then it is a case of postmortem imbibition. But if the arsenic in the soil is less than arsenic in the body, then it means it is a case of actual poisoning. So, that is why we are preserving this soil sample. So, soil sample, it is layer by layer removed and it is preserved for this toxicological analysis. And whatever you are getting, you have to do the autopsy, and if any like bullet, anything is found in the body, you have to preserve them for further analysis. Whether the first autopsy was done, you have to identify, and whether the report is corroborating with the finding that you are seeing now, that thing you have to write down in the exhumation report. So, this exhumation, it can be also asked as a 2-mark question, and this is kind of important. So, these are the autopsy techniques that we have to know for sure, starting with the incision, organ removal and the sample preservation. This is very, very important. With this, we are concluding this autopsy technique. Thank you for watching.